Good morning, everybody. We start with, perhaps it's a hard subject for the morning, the transcranial magnetic stimulation and the effects on chronobiological hypothalamic pituitary thyroid axis in depressed patients. I come from France.
I'm so sorry.
And especially Rouffa, which is a small city but with a big hospital. It's near Germany, and it's a region famous for the production of it. Voilà. It's a region very famous. It's not time, but it's very famous production for white wine, which is our local psychotrope. We're involved in the research of biomarkers in psychiatry for about more than 30 years, and especially neuroendocrine markers. As you perhaps know, when there is an increase or decrease of thyroid hormone production, there is often depressive symptoms. Generally, in depressed patients, the thyroid function tests are within the normal range. Thus, you find nothing. But there is something, in fact, to find. It's useful to recall that the hypothalamic pituitary thyroid axis is organized hierarchically. Here you have TRH. TRH is the neuropeptide synthesized in the paraventricular and supraoptic nuclei. It is released in the portal system to reach the thyrotropes of the anterior pituitary, and it stimulates production of TSH. TSH stimulates the production of T4 and T3. T4 and T3 are the two hormones secreted by the thyroid gland. And T4 thyroxine is the prohormone, and it's converted in T3, triiodothyronine, after a deiodination. And in turn, thyroid hormone inhibits production of TSH and TRH. Other inhibiting factor exists too. Serotonin is an inhibiting factor of TRH secretion. CRH and cortisol inhibit TSH production. Dopamine too. Somatostatin and endorphins inhibit TSH. Dopamine at the level of the hypothalamus increase TRH production, and norepinephrine via alpha-2 receptors stimulates and via alpha-1 receptors inhibit TRH production. It's well known that depressed patients have alteration of the circadian system, and especially the thyroid one. TSH, for example, is not secreted during night, or not secreted, in fact, it's a big word. No, on pourrait aller en arrière, voilà. It's at night there is not the nocturnal surge of TSH. In remission, the secretion of TSH is normal. Thus, it's a state marker of depression. However, it's very difficult to do this kind of procedure because patients need to have its environment synchronized, and the sampling of TSH during the 24-hour span is very complex to do. Therefore, we imagine, and we had created a procedure more easily practicable using the TRH test. TRH test is a test usually performed in the morning. Usually performed in the morning, and it evaluates the secretion of TSH at a time of a day, in fact, where the thyrotrope is not very active. Thus, in depression, only 20% of depressed patients have a blunted response to the TRH test when it's performed in the morning. It's more logical to do it in the evening at 11 p.m., for example, when the thyrotrophs are maximally active. When we perform the test in the morning and in the evening, we see that in the evening, here, the delta TSH is the difference between baseline and the peak after secretion by TRH. In the evening, delta TSH is increased compared to the morning, both in controls and in depressed patients. However, as you can see, in the evening, there is a significant difference between controls and depressed patients. This difference does not exist in the morning. From a pathophysiological point of view, the blunting of TSH response corresponds to downregulation of the Pituitary-Thyroid receptors, secondary to TRH hypersecretion, secondary to increased activity of stimulating factor or decreasing activity of inhibiting factors. Now I would introduce a very sensitive measure that we have called delta-delta TSH. Delta-delta TSH is the difference between evening and morning TRH TSH response. It's the difference. It's very simple. In fact, delta TSH in the morning and in the evening are very well correlated. And delta-delta TSH is also correlated with TSH in the morning and in the evening, but more with the evening TRH TSH response. Therefore, it is interesting to see that it marks the chronesthesia of the TRH receptors. Delta-delta TSH is also correlated with the mean secretion of TSH, that is the measure. Correlation is not fantastic, but in fact, with the group, it's very significant. Therefore, delta-delta TSH is a good biomarker of the chronobiological activity of the thyroid hormone, of the thyroid axis. In depression, here, you have very often a reduced response of the delta-delta TSH test. It's occasionally blunted in schizophrenic patients, but very often it's also reduced in schizoaffective, which is a form of schizophrenic and mood affective disorder when they are depressed. Therefore, we can say that the delta-delta TSH test is a good chronobiological marker of the HPT axis in patients with affective disorders. From a pathological point of view, blunted delta-delta TSH takes into account 4 components. The first one is a chronobiological component, that is the determinants of circadian TSH secretion, since delta-delta TSH is correlated with measure and amplitude of TSH. A chronesthetic component, since hyporesponsivity of TRH receptors, which is greater in the evening, is correlated, delta-delta TSH is correlated with delta TSH, the evening delta TSH. It's secondary to an increase of TRH stimulation. A dynamic component, decreased TSH resensitivity in the cytotrophs during the day after the first test, since TRH stimulates preformed TSH, and a self-regulating component, that is the dynamic characteristics of the negative feedback of the thyroid hormone. As you can see, delta-delta TSH is very useful to test all these components in depression, and that explains why it's often reduced in depression. It's also useful to see how evaluates the delta-delta TSH during antidepressant treatment. In this study, as we can see here, the normalization of the delta-delta TSH test is only seen in responders, not in partial or non-responders. As you see also, we used different drugs, amitriptyline, fluoxetine, toloxetine, and the response is not significantly influenced by these drugs. It's in fact influenced by the outcome. In this study also, we wanted to see if performed early in the antidepressant treatment, the delta-delta TSH test can be correlated with subsequent evolution of depression. And that's the case, since after 2 weeks of antidepressant treatment, normalization of the delta-delta TSH test is well correlated with subsequent response after 6 weeks of antidepressant treatment. Normal values are also well correlated with subsequent response, while reduced responses are correlated with treatment resistance. And that's the subject of today. We speak about treatment resistance in depressed patients, and we wanted to see the effects of the repetitive transcranial magnetic stimulation. It's very complicated. RTMS, it's more simple, on the HPT axis activity. We studied, it's a preliminary study. We studied only 13 TRDs, treatment-resistant depressed inpatients, with blunted delta-delta TSH at baseline. And after 20 sessions of RTMS, we used a procedure, we will see that after the ITBS, it's a theta burst stimulation. On the left dorsal prefrontal cortex, the delta-delta TSH test was repeated in all inpatients. It was inpatients. The 17-item Hamilton Depression Rating Scale was used to quantify the severity of depression, and during all the RTMS sessions, the antidepressant treatment, since it was an add-on therapy, the antidepressant treatment was not modified to do not induce a bias. All the patients included were free of medical illness, and they have no history of drug abuse, alcoholism, or suicidal history, because TRH test in suicide is different. These patients had no history of suicidal behavior, and of course they have no contraindication to RTMS. RTMS, here you can see the main contraindication. In fact, it's metal objects in the head or in the neck. Dental fillings are not a contraindication. Stents and pacemaker is also a contraindication. Given that RTMS can provoke seizures, epilepsy is a contraindication. In fact, it's a relative contraindication. Oh la la. It's a relative contraindication, since we can perform, if the epilepsy is well stabilized, inhibition. We use inhibition, a protocol of inhibition of RTMS, because there are two kinds of protocol of RTMS. RTMS is simply a series of magnetic pulses on the brain through the skull, and this magnetic pulses become electric fields, and they modify the activity of the cerebral cortex. You can stimulate the cortex using frequencies of more than 3 Hertz, or inhibit it with frequencies of less than 1 Hertz. In our study, we used high frequency, it's ITBS, we will see that after. The coil is applied on the prefrontal system, and it stimulates neurons. And it's interesting to see that frontal neurons are well connected to the limbic system, and they inhibit the activity of the limbic system. In depression, the limbic system is overactive. Therefore, we can think that RTMS can treat depression by inhibiting finally the hyperactivity of the limbic system. And why this limbic system is overactive? Perhaps because there is a disconnection between the prefrontal and the limbic system. This short pulse of magnetic focuses on the limbic system, and they trigger electrical charge, causing neurons to become active. We can simply summarize the activity of the RTMS on the neuroplasticity at the level of the circuit. There is an increased activity and an increased connectivity, and also a stimulation of the white matter and the gray matter too. At the neural level, high frequency, non, c'est là, high frequency, yeah, or ITBS, intermittent theta burst stimulation, increase excitability and decrease inhibition. At the level of synapses, there is an increase of BDNF release, which is the brain-derived neurotrophic factor, very important in the neuroplasticity effect, and stimulates also dopamine release, GABA and glutamate. The effects on serotonin are mixed. We use in our study the intermittent theta burst stimulation. Intermittent theta burst stimulation consists of applying over the left dorsal prefrontal cortex for 5 minutes, short term, but with high frequencies, because theta burst is 3 pulses of stimulation given at 50 Hertz. It's really important. And it consists after the parameters, 10 bursts per 1 second train, inter-train interval, it's 8 seconds, number of train 30. The magnetic field intensity is 100% of the resting motor threshold. This motor threshold is determined at each session before giving the magnetic field, the ITBS. Number of pulses per session, 900. Each patient received 20 ITBS sessions, single daily session, and 5 sessions per week. The effect of RTMS on the depressive symptoms are clear. RTMS diminishes the symptoms of depression. It's very significant, as you can see here. And if we use a threshold of 8 to the Hamilton Depression score, at endpoint, we had 6 responders and 7 non-responders. Now, regarding the evolution of the delta-delta TSH test, we see that there is an increase in delta-delta TSH values. However, at endpoint, the level of these values remained lower than those of matched controls. Which is interesting is that we had 7 patients who normalized their delta-delta TSH, and 6 patients who did not normalize the delta-delta TSH. And when we looked at the responders and the non-responders, we see that responders had all responders had normalized their delta-delta TSH values, while non-responder except one had low delta-delta TSH values. There is no change, in fact, of the delta-delta TSH values in non-responders. This association is very significant despite the small sample, and therefore we can conclude that the effect of RTMS on the delta-delta TSH is not direct. It's correlated with clinical improvement. When I say it's not direct, it's not. That is really the question. We will see that after. There is also a relationship between the delta-delta TSH values and the scores of the Hamilton depression at endpoint. The lowest, the depressed Hamilton score, the higher the delta-delta TSH. There is also a good correlation between the evolution in terms of percentage of evolution between baseline and endpoint between delta-delta TSH and Hamilton score. Therefore, it's clear that the delta-delta TSH mark also the improvement of depressive symptoms. If we try to summarize our findings, we can say that in TRDs, in treatment-resistant depressed patients with at baseline an alteration of the chronobiological HPT axis activity, delta-delta TSH is blunted, and it's correlated with an increase of TRH secretion and a hyposensitivity of the TRH receptors. This increase of TRH secretion is probably secondary to increased activity of the limbic system due to the disrupted connection between the prefrontal system and the limbic system. Therefore, the limbic system cannot be inhibited by the prefrontal neurons. In responders, the delta-delta TSH test is normalized. That means that TSH and TRH secretion are normalized. And this is an indirect marker of the activity of the limbic system and the prefrontal cortex. In this case, the limbic system is normalized because the prefrontal neurons can inhibit the limbic system. The stimulation by RTMS restored the connectivity between prefrontal system and limbic system. In non-responders, the prefrontal and limbic system remain disrupted and disconnected. Therefore, the delta-delta TSH is reduced. I hope that you are not tired. In TRDs, with chronobiological dysregulation of the HPT axis at baseline, chronobiological restoration of the HPT axis activity after 20 sessions of RTMS is associated with clinical remission. Our hypothesis is that successful RTMS treatment can restore the functional connectivity between the prefrontal cortex and the limbo HPT axis, thereby allowing normal inhibitory feedback on the hypothalamic TRH neurons. delta-delta test normalization could be a potential biomarker of functional recovery of the frontal limbic system. Of course, further study are needed to confirm this hypothesis. We continue this study with also TRDs without HPT axis abnormality. Because we wanted to see if these patients without chronobiological abnormalities respond better to RTMS. That's a hypothesis. Thank you.